Hi, okay, thanks, Marlon. That was Dr. Marlon Mouse, who's on the faculty at the Public Health School and a colleague of mine. He runs the DRPH program, which was the one that I graduated from. My name is David Saylor. Thanks for all of you to be here. It's great to be having this event. We also have, I think, 120 people online at least watching, so hopefully more maybe will join us, and I'm sure some people will watch the video. So my name is David Saylor. I'm at the Center for Global Public Health, which is part of the School of Public Health here. And I'm here because I've been involved in this issue the last couple of years, mainly, and I just wanted to sort of set the scene a little bit, and then I'll introduce the panelists, and they'll each introduce themselves for a minute or two, and then we'll open it up to questions. And one of the things that's, I think, great about this film is that it's appearing at a time when we're really seeing a lot of change in this illness. I think the last couple of years, especially, in 2015, there were a couple of major events. One was that both the Institute of Medicine, now the National Academy of Science, and the National Institutes of Health both had panels which did extensive surveys of the literature, and both basically pointed out that this was a very serious disease and not something to be taken lightly, and had nothing to do with psychological or psychiatric problems, except that people got depressed afterwards. So of course they sometimes did have some issues with that, but that fundamentally this was a physiological organic disease that was not caused by false cognitions or deconditioning or anything like that, and that it needed to be taken seriously. Around the same time, the National Institutes of Health and I think other agencies started to take it more seriously, and I think we've seen in the last couple of years a ramp up of, not enough, but some ramp up of research, and we have two experts here on the panel who have been involved in doing some of that research. And I think the third thing is that we've seen a real movement against the cult of cognitive behavior therapy and graded exercise therapy, and the basically pretty, I think, sketchy research that's been published to support that. And that's been partly my role, where I've been spending the last couple of years doing reporting on some of this terrible research and trying to get it at least discredited, if not retracted. So I think all those things are coming together, and I think the movies come together at a good time to capitalize on those developments and help create a lot of awareness, hopefully among some people who didn't know about it before, to give an idea of what the illness is like. So before I introduce the panel, I just wanted to get a show of hands of how many of you here are actually patients with ME? Okay, so most of you. How many of you are carers of patients with ME? Okay. And how many of you are just here because you just don't really know much and are interested in the issue? Okay, good for you. Thank you very much for being here. That happens too rarely. But anyway, I think that gives us a sense of who's in our audience. So most of you are sort of familiar with some of what we're going to be talking about, and I think that will be helpful. So I just wanted to introduce the panel. First, we have Lily Chu, who's a doctor and also been very active in both at Stanford and in the International Association for CFS ME. We have Dr. Ron Davis, who's a very well-known geneticist at Stanford, and as you have seen from the film, has been working very intensively to try to come up with answers. We have Allison Ramiller, who works with the Solve ME CFS Initiative and is also a Berkley MPH student, and was someone who wasn't involved in this before but has now gotten very involved. And then we have Dr. Jose Montoya, also from Stanford, who's an infectious disease specialist and also a friend, and has been doing really excellent research on this for the last number of years. And so I'm just going to turn it over to each of them individually to talk for a minute or two, and then we'll open it up to questions. Thank you.
Thanks, David. So, hi, everyone. My name is Dr. Lily Chu, and I have a background in general internal medicine, geriatric medicine, and health services research. So I also come from a public health background, and I became interested in this illness a little over 10 years ago because I came down with it myself. And as the film alluded to, you don't really learn about this condition much in medical school. It's hardly ever mentioned. So I found myself trying to learn as much as I could. Since then, I've been involved in a number of different projects. I sit on the advisory board for the Stanford ME CFS Initiative. I'm the co-vice president for the International Association for CFS ME, and I've advised on a number of different federal projects, including the National Academy of Medicine report that David alluded to. Ron?
I'm Ron Davis. I'm a professor of biochemistry and genetics at Stanford. I'm also the director of the Stanford Genome Technology Center, where we developed a lot of the technology for doing the human genome sequence. I've turned that technology focus on medicine, and we develop a lot of new technologies and measuring techniques. Most of it's focused on reducing cost. When my son became sick, it was clear that I had to terminate a lot of those projects, which I have been doing, and focus on chronic fatigue syndrome research. The difficulty is the funding, and I still do not have an NIH grant. I've written several, but I've been very fortunate that the Open Medicine Foundation just in the last several weeks got a donation of $5 million for and that was from the Pineapple Fund, and in fact, the patients themselves were actually quite responsible for that by pitching in and writing support letters and so forth.
Where was that from?
It's called the Pineapple Fund. It's an anonymous donor. The money came from an early investment in Bitcoin. I think they bought Bitcoin for $1 a piece.
They got the money before Bitcoin fell a couple of weeks ago.
Yeah, and yes, and we got it when it was $16,000 a coin. So that's a good markup.
They also just gave $50,000 to ME Action, I saw today.
That's
Pineapple
great.
Fund, yeah.
Yeah, that's great.
So they're giving away, they seem to recognize that it's an important issue.
Yeah, that's great. So I have a research group that's pretty multidisciplinary, and I'm trying to recruit other people to work on it. We really now have sort of an international group that we call our working group. We try to coordinate and share data. We put up a portal recently that has data that people can access, and trying to get a lot of other people to put data into this portal. One of the problems is that when we do our research, we create a very large amount of data. And I saw in the movie a little bit, we've increased that by a factor of 100, maybe 10 to 100. So it's so much data, it's almost impossible to look through it without a computational analysis. But that's showing us a lot of patterns. It is very heterogeneous disease, but we keep coming up with ideas and theories. I'm still pretty optimistic that we can track this back down to the original problem. I suspect there's a single cause, and that there's a lot of heterogeneity in how it's expressed. And we shouldn't be focusing on the heterogeneity. We should try to focus on what's actually initiated it. The fact that it happens like overnight in some cases, I think this can't be super, super complicated. We have no idea what it is, though. And so I think when we figure it out, we'll say, oh, God, I couldn't believe it's so simple. But you have to look in the right place. And to do that, we need lots of people. We need lots of really good scientists looking in lots of places. We need really good scientists to do what they do well. I don't like the competitive model of science. Some people do. I think science is hard enough as it is without worrying about somebody else doing and stealing your data. So I think we need to get a bunch of really cooperative scientists together and share everything and be in this together with people doing what they really do best. And I think we can do that.
Hi, everyone. So my name's Allison Ramiller, and as David said, I'm a second-year student at Berkeley's online Master's in Public Health program. And I'm also affiliated with the Solve ME CFS Initiative, which is a research and advocacy organization that works exclusively on ME CFS. So it's a privilege to be here and speak from both of those perspectives today. And I mean, as you saw, the Unrest documentary is a really powerful depiction and brings into such sharp focus how medicine and society at large has really failed individuals with ME/CFS. And personally, I've always been drawn to public health and social justice issues. But prior to interviewing with my current organization, I knew very little about this disease, and what I did know was misperception. So this is such an important tool, and I like to think I'm part of a trend of increasing awareness and we need that. We need broader engagement and support from a broader swath of people. So, but again, there's been some progress in recent years. Some amount of increased funding, although still not enough, and really robust advocacy action. And that's what we like to focus on at the Solve ME CFS Initiative. We want to increase funding streams, bring more researchers to the table, create a tenable environment for them to pursue promising lines of inquiry. And science is most often an iterative and collaborative process. And one other aspect we're really focused on is improving data collection and being a part of some of the broader efforts that are going on around the harmonization of data and allowing for better comparison across studies. So, just to close, after watching this documentary and listening to my fellow panelists who have so much experience and perspective, particularly for those of you who are unfamiliar with the disease, I hope that you feel as galvanized as I do to either lend your expertise or just lend your support in any way that you can to individuals with ME/CFS.
Jose Montoya, as David presented, my training is in infectious diseases, and I still devote a great part of my time to that, and I'll explain in a minute why. I see patients with cancer and transplant who get infected. In fact, I founded a whole service at Stanford that is just devoted to attend the infectious diseases needs of these patients. And also I direct a national laboratory for the diagnosis of toxoplasmosis for the US. And when I got into this, at Stanford, we were told that we should not see patients with chronic fatigue syndrome or chronic Lyme disease. And there was, in fact, a letter written that went out to physicians in the community so that these patients will not be referred to us. So the day one, the day zero for me was when I saw a patient like that. And I just couldn't stand seeing the suffering in that other human being. I think that ME/CFS is a test for human empathy and for what we physicians are supposed to be doing. We are trained allegedly to heal. We are trained allegedly to bring down suffering and not to judge. And the biggest misconception that talking about misperceptions that we have made in medicine is to have led to the belief that these patients have created the illness in their own minds. And so the origin of why was on that number one patient that I saw destroyed like this. And in fact, we have made some progress, and I agree entirely with the rest of the panelists and with Ron, that we are turning the corner. We have a study suggesting that there is an area of the brain that is clearly abnormal, and we are now in the process of trying to validate that as a biomarker. The data that is coming from several places clearly supports the view that this is an overactive inflammatory disease. And it's funny, Ron, because what really put us on the map with the data that is coming from us came also from a private donation that happens to be at the same amount that you just got now from a private donor. So we cannot wait for the NIH to get to census to do what they need to do. Obviously, as Ron mentions, we have to insist in knocking the door, but not wait for that to happen. So as a testament of the work that is done at Stanford, a good number of members of the team that we have are here tonight, including Dr. Bonilla right there. Amity Hall, our great PA, who is a Berkeley student, former. Juliana Levy, Alisa Aguilar, our clinical research coordinator, Tulia Lieb, and Katia Lavin. So thank you guys for being tonight here with us.
I think we'll just open up to questions at this point.
Just raise your hands.
Hi, my name is Kristen Luger. I'm a sociologist, and my question is something implicit in both what you're saying and in the film, which is the role of political activism. And the question I want to know is, what's the take-home from the way AIDS activists pressured the government to begin funding AIDS and HIV more generally at a substantial level at a time when it was quite a stigmatized disease, nobody thought it was very interesting, and political involvement, I think, really changed the picture, and I think we have a pretty rich literature on that. So how do we move, and again, it's a subtext in the film, but we don't really know how it happened. How do we get to the next stage of political involvement to start putting pressure where it counts?
I'm going to speak a little bit about that. So actually, David can talk about that too, because you were involved in activism back then, so he's going to talk about that a little too. One thing is, and I've taken care of HIV patients. I've had friends who are affected by HIV. They're healthy during the earliest stages of their illness, so they have the benefit of being able to go out there more and talk and get involved. And with ME/CFS, the case definitions, you're already at least 50% down from your normal function when you are affected by this. So it's very difficult for many people, as you can see from the film, to get out there and really show up at their congressman's office or even at a protest. Having said that, though, I always encourage people to do what they can. There's so many ways to reach your members of Congress or even your state representatives or even your mayor or your city council member. Email, fax them. If you can't go, have your family member go for you. David?
I think one thing that is sort of horrible to say, but the sort of, quote, lucky thing about people with HIV was that they were dying. And so in that sense, even though people didn't care about them, and I'm, a 61-year-old gay man, so I was living in New York at that time when everything was starting. So nobody cared, but you couldn't pretend that people weren't sick. Like, you couldn't pretend that people were making it up, or that they were just malingering, or they didn't want to go to work, or that they just had some psychological problem. So one huge distinction that makes it much, much more difficult in this circumstance is that, again, you don't want people to die, but when people are dying right and left, you can't pretend that they're not sick. And I think that creates a real, we're still fighting this idea that people aren't really sick. And, it's crazy. I mean, I don't understand it. It's really driven me insane the last couple of years to be writing this stuff and, exposing articles that are horrible in the literature, and then have the journals just ignore these really egregious flaws. And I don't understand it. But anyway, that goes back to your question about AIDS. I do think that there's obviously a lot in terms of the theatricality and in terms of the performance that people have started to take on, like the Millions Missing and the Shoes, and kind of the idea of doing a theater. And I think that's had some progress in the last couple of years.
Yeah, and I'll also say the Solve ME/CFS Initiative has really taken up a more robust advocacy platform. And last year we did a series of meetings. It was like a patient advocacy day. And we're going to be doing the same again this May. And they did some creative things to better enable patients that could come to participate, like having an area where patients could take a break and then get back into it when they're able. So I think, that's something to watch out for, and that's something that I think, getting these folks into the congressional offices is extremely powerful. And as Lily said, that hasn't always been a possible thing. But so watch out for a notice to go out for our advocacy action in May.
Yeah, a large fraction of the patients are either housebound or bedbound. I mean, they're seriously ill. They really couldn't go out and protest. So that probably accounts for half the patients. And then the ones who aren't don't look sick. I think that's a problem. When my son was really suffering, he did not look sick. We look at his pictures today. He does not look sick. He does now because he's emaciated and he's bedbound. But it doesn't work well. That's the problem. Like, we might have to be creative and try a different tactic than copying the AIDS demonstrations.
And I think that also we need to take advantage of the things that were not available back in the 80s when the AIDS activism, the social media that is present today. Back then, the news traveled by newspapers and TV. But for example, we were taught in our team by Juliana Levy, who just put a Facebook. We have not even thought about Facebook page, and it was an instant success. And then suddenly the patients were communicating with us and coming. So maybe the way to set up this protest could be through the media, as is implied in the film as well. But I agree, breast cancer is the other example where patient activism led to investment in research and bringing progress.
I will say that one of the similarities is that, of course, in the 80s when ACT UP came in, and people started, the patients started to become experts in the drug development process and in sort of how the drugs were working, and it's really the same thing here. So a lot of my work has been about writing about the studies, but I really rely on the patients who are incredible at deconstructing these studies and have for years pointed out all the flaws in all the studies promoting cognitive behavior therapy and exercise therapy, but nobody pays attention to them as much because they're crazy patients or hysterical patients who can be sort of dismissed. And so, but they've done incredible analytic work, and many of them are scientists themselves who've just happened to have gotten sick. So I think in that sense that it's, it's an incredible resource, and they've really been done great, incredible activism work just from their beds. Yeah. Oh, you have one, okay. And then...
Hi, I just want to add something because I'm involved with ME Action, and I can't emphasize enough how much we need volunteers because, as everyone has said, the patient community is too sick generally to advocate for themselves. So if you are interested in getting involved, go to the Solve ME CFS Initiative website and go to # ME Action, where we have congressional teams working on congressional advocacy. As she mentioned, I was there last May. We also do calls to action on social media. So if you want to get involved with either contacting anybody or offering your time, please go to our websites. We desperately need you.
When you head in on the table, there are actually some page with the Unrest film on it. At the bottom, there's the website, Time for Unrest, and that will connect you to some of these resources. So take the sheet out on the table if you didn't. There's a gentleman up there with a question. Can we hand the mic up to him?
I can speak loudly.
Okay.
Wait, I had a question right here.
No, he was
First.
Go ahead.
Hi, my name's Dianna Schweickart. I've been chronically ill for over 20 years, and I try to pay attention to what the latest research is. And I just recently learned about a Dr. Sharon Meglathary. She's apparently in touch with you, Ron, and she has some RCCX theory, a genetic theory about what's sort of the root of all of these different autoimmune, mysterious chronic illnesses. Can you speak to that?
I get almost daily something from a patient with an idea. I read them all. I investigate them all. Sometimes I pass them on to other people where they're more expert in those. The patients do spend a great deal of time. I'm worried that a lot of the patients can't get access to the journals because they're restricted in many cases, and so we're making a big point when we publish, it will be an open access journal. We will never publish in one of these closed journals. So I think some of them have a great deal of merit. Some of them I don't think do. I don't want to be negative to them. I keep them in the back of my mind and try to think about it. And some of them we will actually undertake some exploration of.
This is a doctor named Sharon Meglathary, and she suffered herself, and she quotes your research.
Yes.
So I'm just curious if there's something about this RCCX theory that you have done research on. I'm
skeptical,
Okay.
but I don't want to put it down,
Okay.
right?
I appreciate that.
I do get an awful lot of ideas, but I think that's great. We have to be in this all together to solve this disease.
Thank you.
Hi there. My name is Dana Ullman. I'm a graduate of the School of Public Health back in '78. When at the time I was really interested in alternative medicine, something specifically called homeopathic medicine, which we call nanopharmacology today. And as it turns out, I'm sitting by an old colleague of mine who's been greatly helped with homeopathy with ME for many years. And to me, I mean, this is a type of syndrome that we need to explore all types of methods. And I'm just curious if any of you have had patients that have explored homeopathic medicine, Ayurveda, acupuncture, because these are systems that aren't treating diseases per se, they're treating syndromes. And it's this type of thinking, homeopathy specifically as a method of augmenting immune response, that sort of makes sense as a potential treatment.
So I think that it's hard to comment on specifics of interventions because of the disease's complex itself. It becomes sometimes difficult to assess the impact of a drug or a system or a science, and it becomes really important in those cases to go to randomized clinical trials where you can really have the arm that is blind, the other one that is with the intervention, and those things unfortunately cost money. But I think that ultimately, when we are closer to understand better this disease, that would be the way to go to really demonstrate the efficacy of an intervention.
It's hard to get parallel groups.
Yeah. Well, parallel groups.
I wanted to comment on your question too. Now, let me preface this by saying that the paternal side of my family were interested. Their work was in traditional Eastern medicine, Chinese medicine, and then in medical school, I went to China and spent 6 weeks there observing acupuncture, and later I looked at trials where they looked at back pain and whether acupuncture helped or not. And what it struck me was how hard it is, as Jose alluded to set up clinical trials where you're using alternative medicine. In the case of acupuncture, there are different styles of acupuncture, for one thing. Secondly, it's a very individualized therapy, so it's hard to compare from one person to the next. And then there were issues like, what do you use as a control, as you alluded to? And lastly, what do you use for an outcome measure? And in ME/CFS, there's a lot of debate about what are great outcomes to use, other than just subjective outcomes.
Yeah, we'll go back and forth, one side of the room, and then,
I have a daughter who's being treated at Stanford for ME/CFS, and it's been about 6 years for her. My son went through a version of it. It seemed he had a similar thing happen at a similar age. He was like 13. They both developed something, and he pulled out after about 6 months. And so I guess my question is, I also have another friend who seems to have a son who's developing it, who has it, and it seems as though this running in family thing is something that we see repeatedly. And I guess my question is does there seem to be is that a real phenomenon that is bigger than what I'm just imagining? And maybe secondly, are there people who, sorry, is there some sense that there may be many people who get a mild version of it, and that the severe ones are the ones that we really pay attention to, like maybe my son's 6-month version of it? Are there many of those people out there, or is it typical that it's really one or the other?
I can answer part of that question. There are actually quite a large number of families with multiple affected. And so we've decided to study that group of people. But what we're studying are the people affected in those families and also other members of the family that aren't affected. And that's turning out to be a very useful way to look at it, because we have more than one and which share a lot of genetics. They share the same environment, they share often the same diet, and it removes a lot of the variance and it allows us to see a lot more that's going on. the general hypothesis is that there's a susceptibility based on genetics. We don't know if that's true, but that's what we're looking for in these families to see if we can find out what that is.
And following up on that, in a study we did, if a patient has CFS, they have a 14%, in a study of CFS patients, 14% they will have a family member, whereas if they were healthy controls, less than 1% will have a CFS member. And so, let's not lose perspective that the same insults, i.e. these infections, for example, that lead to CFS are the same ones that everybody else is getting, but it's not going into CFS. So there is obviously a spectrum there as well. But what makes humans react with this horrible disease that gets self-perpetuated but doesn't kill them? Because there is some wisdom there. Unfortunately, it's a wisdom on a bad thing. But the patients, as you pointed, they don't die physically. They do have some higher mortality. That's well known as well. But what leads your son to get out in 6 months, but your daughter stays 6 years? But everybody else who gets it recovers from that.
I had just one general question. My name is Michael Harbour. I actually used to practice with Jose years ago at Stanford. But what's the distribution plan for this film? Because I think this is it really touched at my heartstrings, and that's how you begin to take away that stigma of, oh, that's just a malingerer or that's something. So I don't know if anyone knows how this film may be distributed.
Well, I don't know about. I mean, I know it had a theatrical release, and it was on PBS, and it's been used a lot.
Netflix.
Hmm?
I think it's on Netflix.
It's on Netflix
Oh,
and
it's on
iTunes.
Netflix now?
Netflix
It's been used a
and
lot.
iTunes.
It was on the short list of like 15 or 18 for Oscar nominations, but it didn't make the list of 5. But it's been used a lot. Like I was in a screening in Leiden and in the Netherlands, and I was on a couple of screenings in London, and it's been used everywhere for screenings like this with panel discussions for awareness. And then when I was talking with Jen, if you go to berkeleywellness.com, there's a Q&A yesterday with Jen Brea that I did from the film, and she's trying to get it out into medical schools, because one of the problems that you see is that doctors don't know anything about it, or they think it's psychological. People get referred to a psychiatrist, so they wanted to get it into medical schools and try to start getting it into the CME curriculum in some way. So I think they're thinking about it in that way.
Perfect.
I just heard that it is going to be part of the CME. They're just going through
They're going through some process
for
of trying to get
CME.
it
Yeah, great.
CME approved.
The other medical question I had, just to follow up, was, is there an animal model or some analogous ways to study it in an animal that you're aware of? Any type of zoonotic similar symptoms?
There was one animal model that was in small primates. Unfortunately, the researcher who was working on that got stuck himself and developed chronic fatigue syndrome and had to abandon the entire thing. Fortunately,
How did they answer the subjective questionnaires about fatigue and physical function, I wonder?
well, they are very clever. How much time they spend moving around, how much time they watch TV and things like that. So there are clever ways to find out where the animals are sick. But I'm going to say they, to not say it's a he or a she, but they got really sick, it's one person, with chronic fatigue syndrome. And fortunately, pick up the virus from their blood. And with the treatment, got back to normal. So that's for, it's going to be hard to set up that animal model with that precedent of someone getting infected so badly and developing bad chronic fatigue syndrome. But that would be another way to answer this question.
I could put a little negative point of view of that on it because of the fact that when you have a complex disease, sometimes the animal models don't work very well. So I was involved in a long-term trauma study. This is of physical accidents, burn and blunt force trauma like auto accidents. And they go into sepsis frequently, and that's when they get multiple organ failure and die. A lot of work was done on mice, and because it's cheaper. And the FDA requires a new drug to be tested first in mice to show it works in mice. And there were 160 drugs developed for sepsis that all worked on a mice, and not one of them worked on human. So we are very similar, but we're not identical. And so it can actually slow down research if you get too heavily focused on an animal model. I'm not opposed to it, we just got to be careful.
I have two comments, quick ones. First is there have been studies on models in rats of chronic fatigue syndrome, not so much in the US, but I have a problem with them because usually they define chronic fatigue syndrome, they induce it by having the rat run on a wheel for extended periods of time, and that is not the way most people develop ME/CFS. 80% of cases develop, up to 80% report an infection before. So if you're going to have a model, that's not the model you want where the rat is being induced by having them run on a wheel. Secondly, the other issue is there's some very interesting work looking at autoantibodies in ME/CFS right now, and so I'm interested to see if there's a way that we can use a model where we transfer antibodies from a person affected by this into a rat model, because that's one of the ways you can prove that an illness has an autoimmune basis.
I just wanted to quickly say that we have over 80 questions online, and just a couple comments is I love seeing Ron and Jose joining forces. Thank you. We have people from as far as New Zealand and other places. I can't imagine what time it is there. And really quickly, hello from Barbara Ramiller, which I assume is a family member, but she's watching.
Okay.
That's great. I didn't know she was on Facebook.
Question here.
Hi. I got the impression watching the film that there's viral infection is one of the thoughts for what is triggering this disease. We've heard other people talk about genetics. There were also hints that environmental factors may play a role. It's complex. There's also a large community of people who are now getting involved with the disease and could potentially contribute data to help understand what's going on. I'd be very interested to hear from the panel what kinds of data you would most be interested in collecting from the community. We have all kinds of new tools now with the internet, tests which can be delivered by mail and measured at laboratories. Where are the most interesting places? Environment, medical tests, genetic tests, in your opinion, for this disease?
Yeah, so I kind of alluded to this in my opening remarks, but the Solve ME/CFS Initiative is currently working to establish a national ME/CFS patient registry, and we're doing this in partnership with the Genetic Alliance. They have established a platform that's called the Platform for Engaging Everyone Responsibly, and it will incorporate electronic health records, eventually, genetic data, and the part that's really important to us. And something that's been emphasized in my coursework at Berkeley is the importance of community perspectives. And this registry will actually have a direct portal for patients or their caregivers to enter information in a well-characterized set of surveys. We hope to collect longitudinal data. So, this is still in development, but it's a capacity building thing that will also be able to grow. The Genetic Alliance has a lot of plans to grow this within a network of diseases and allow comparability. And so, I think we're really interested in a lot of forms of data. I know a lot of the research that you're doing is in that trend as well. So, yeah.
There are a lot of, we didn't talk about it so much in the film. There's some information out on that handout in the table out there. There are some tests that are promising for helping clarify or support a diagnosis of ME/CFS, even though there isn't a specific diagnostic test. Ron and I were both on the National Academy of Medicine panel back in 2014, and we reviewed a bunch of these tests. What I would like to see is a study where you take a defined group of people and you have them undergo all of those tests. So you can start to look at subgroups. You can start to see which are the most common abnormalities people have, et cetera. Because a lot of times you have these small studies where they focus on one abnormality or another, but you don't really have a big study where you get to see all these different tests in the same people.
Can the 2-day CPET test be used as a, diagnostic? What prevents that from being used regularly? Is it that it makes people sick, so you can't really do it ethically, or what's the? It hasn't been replicated enough? What's the problem with that?
The 2-day exercise test?
Yeah, the 2-day exercise test.
I think people are worried about making people worse. If we had a way to measure their safe limit, it might be used more, but I think most people are really worried about it. I think some people are going to do it anyway as a study because we feel we have to, because that's when they do exercise, that's when they are really expressing the disease. So when we look at patients when they're feeling good, it may be misleading.
It clearly will exclude those who are bedridden, who will not be able to do the exercise test, those who are in bed. Another thing for you is a call. We have received a great response in the studies that we are conducting at Stanford, but we make a call for even more participation. So we have now 4 studies that are being carried out. One to validate the neuroanatomical finding as a biomarker. Second one is to see inflammation. There is a way possibly to see the inflammation in the patient's brain. Another is devoted to just women in childbearing ages to see the neuroendocrine system. And we have a fourth on chronic Lyme disease, because we are also worried about patients with chronic Lyme disease to see how similar or how dissimilar are from chronic fatigue syndrome.
Hi, I am a patient of chronic fatigue syndrome, and my question has to do with why didn't the documentary explain some of the work that that some of you were doing to explain, to explain what evidence you found so far, what you're speculating even, because I think just having it at that scale will help patients like myself to even introduce conversations with our physicians and people in our lives, even if we don't have complete answers. I'm, trying to do that on my own, but it's not very effective.
I think it had to do with the timing. When the release of a film, it means that it was done a year or 2 years earlier, and this data showing the brain abnormalities and the inflammation by several groups is just coming out. Like the big data on inflammation came in the 2017 summer, and the film had already been performed. But I agree with you. We need another thing that I have a sense, David, that, and we haven't talked about this before, because I really love talking to you and respect you. But I think ME CFS is set to increase in numbers.
Right.
As a human race, we are changing the immune system over decades. So we get invaded by infection. From the 1300s, the plague, then in the 1800s, malaria, yellow fever. Then we have the flu now visiting us every year. And there are people who are selected out, who die because their immune system couldn't cope with those infections. Thinking about trends across centuries. And then you are selecting those with the best immune systems. And that happened in a population in Italy, in Sardinia, where they used to die with malaria. Mm-hmm. And then clearly it was associated with a defect in a specific immune system component, a cytokine. And then decades later, when the ones who died because they didn't have enough cytokine were gone, but the ones who had that cytokine strong were left, then they started to develop more multiple sclerosis and lupus, who are highly immune-activated diseases. So as a race, I think that we are set to see more ME CFS, which hopefully will be one more argument. We have enough arguments already
to support?
To support the assembly.
I think one reason that there's less probably of the that kind of data in the movie, and I asked Jen a little bit about this, is that it's a visual medium, and she felt it was probably best to capture the journey of patients, and that there are other better ways to convey data and studies and that kind of information, and that the documentary film wasn't necessarily the best way to do that.
In fact, I think they did collect a lot of footage of various ideas. I think they chose to cut it out. And I think it's because it's going to get dated. And I think another way to do this is to put out frequent social media types of discussion, which everybody can get access to, make them short so they're not overwhelming to anybody. And then also when we hold like a symposium, put that symposium, make it live, and make it so that anybody can watch it for free. And so I think there's other ways to do this that are probably a lot more effective.
Yeah, and that's something at Solve ME CFS Initiative that we try to do as well, is increase accessibility to this information, because as Ron said, a lot of these journals are closed. So we have a Research First newsletter that we try to push out research highlights on, and we're also starting to do this quarterly a research kind of roundup and try to contextualize the research so that folks can understand how it fits into the canon.
I also think that the director, Jennifer Brea, she really wanted to nail home the point that a big obstacle to why there's not more medical or research interest in this is the lack of education and the misconceptions that people hold about this. I mean, Jose, Ron, myself, we all come from research areas that were not ME/CFS. I originally researched nursing home quality of care. And so I have that, how that field is looked at and how patients are taken care of in geriatric medicine. I compare it to how patients are taken care of for research in ME/CFS. And there's a big disparity. And the reason is that patients with ME/CFS are not taken seriously in the same way that older patients are.
So, when I was getting my doctorate here and in the program that Marlon now runs, I was interested possibly in doing research on this illness. Nobody was opposed to it at Berkeley, but nobody was doing it, so there was nobody to mentor me or nobody to actually help me. And if you're in a doctoral program, you can't actually work on something that nobody in your university is very interested in. So it creates sort of a self-perpetuating, if you say to somebody, I want to study chronic fatigue syndrome, as an academic, nobody's going to take you seriously. And nobody, so I ended up studying something else, but now I'm spending my time working about this. So there's not a lot of support in the academy or in the academic field, and I'm sure you found this in your research as well, Jose and Ron, that nobody wants you to study this, nobody's encouraging you to do it, and if you do it, you're really on your own. And you're really on your own finding money, finding support, resources and all that. And that's really been a huge problem. And I attribute that largely to the CDC naming it chronic fatigue syndrome in the first place in 1988.
I was once said that I was committing academic suicide.
Okay, there you go. I don't talk to editors anymore and try to convince them. I just write my own stuff and post it, rather than trying to get editors I can hear their eyes rolling in their head when I am on the phone and I start saying chronic fatigue syndrome. I think we probably have to...
I wanted to read at least one question from the online people, and this fits very nicely to, just in general, to recommended therapies. It says here, my healthcare provider continues to recommend graded exercise therapy for ME/CFS. Is there anything that we can do as patients to change
Have
this?
them read all my blog posts on Virology blog and and send them to the doctor, and hopefully the doctor will say, no, we're not going to do this.
Graded exercise therapy and cognitive behavioral therapy should not be recommended for CFS blindly.
I think we have one person waiting here. Why don't we have one last question?
Okay. I'm a patient in the Sacramento area, run a support group for probably 20 years. And I have friends who have had some success in the last few years with Valcyte. And the first time I heard about Valcyte was Jose Montoya using it at his practice. I wondered what you thought about patients who don't see you specifically, but have doctors who are prescribing it to their patients.
Yes, it seems to work for a group of patients. It doesn't work for everyone. And we are in a kind of a desperate situation because we don't have enough providers to advise and to suggest. Luckily, we have Dr. Bonilla, Amity Hall, and there is another person joining us soon. But knowing that it does work for a group but not others, sometimes we do have conversations with the physicians and then advise them over the phone as long as the physician is present. Yep.
Can I get a question in?
Sure.
One last question.
Thank you. My name is Eric Johnson. I'm an Incline Village survivor and an original prototype for the Holmes chronic fatigue syndrome. And I noticed straight off that all the clusters were occurring in sick buildings. In fact, every cluster I encountered and every individual patient that I approached had some kind of connection with the sick building. And we actually asked the CDC about it at the time. Of course, they weren't interested. But I chased it down and I found out that all the buildings had toxic mold. This was definitely a factor in the syndrome. But I've been told since then that I have no proof. Now, my question is, as a prototype for the syndrome with direct documented evidence from the original clusters investigated by the CDC, I felt that I have a right to have this investigated. So I was just wondering, what constitutes a relevant clue that warrants attention from the research community?
So what level of evidence should trigger a legitimate investigation into something, more or less?
Well, we did have the sick building syndrome, or the sick buildings investigated, and the finding of toxic mold was confirmed. The problem was that at the time, it hadn't been discovered yet and wasn't entered into the literature. So when Dr. Cheney and Dr. Peterson looked into it, they found no reason to suspect toxic mold as a factor. So in order to take this into account, we would have to revisit these events and take a look at whatever role it might have played.
So what about...
Are there any environmental scientists from public health school? That's one thing I would ask. I will say that for, it's not my area in health services, but environmental factors are hard to analyze because we're all exposed to so many things. And to narrow it down to one factor is very difficult if you're talking about a population. Now, if you're talking about an individual patient, then there's nothing to say you can't go and experiment and go somewhere else for a few weeks. Or, you saw the movie, she went for a more radical way. But, you can see if that makes a difference in your health.
And I'm the person who turned Jim Grant onto mold avoidance. So she did find it to be worth pursuing in her case.
And that's going to be an individual decision. But on a studies level, it's very difficult.
I think that every clue has to be taken seriously, and without forgetting that we need to apply the scientific method and rigor so that we set an example. I think that by studying the way we are doing CFS, there will be other, or ME/CFS, disciplines and other diseases that are going to benefit. But we need to maintain the scientific rigor and the scientific method.
We plan to undertake a study for that. I've talked to you about that too. I think we need to figure out what organism or organisms are responsible, and also then what do they produce. And one of the problems is these mycotoxins, which is what you're referring to, are really toxic. And aflatoxin is the most potent mutagen of any compound known. And they work at very low concentrations. And I'm sure what the molds produce these as a defense mechanism, and because they'll kill off anything. And the technology for measuring their concentration is really not there. And that's one of the technical problems. There are labs which will test it for you, but they're called they're on the quack watch. They're actually below the detection limit of the technology they're using. However, There's new technology out there. That's what we do. And we've increased the sensitivity by 10,000-fold. And we could be able to develop an assay for it. So that is in the plans. It's going to be a long time when we have to be careful not to spend too much money on it, because it will take a time to actually put that all together. But I do plan to do it.
Thank you.
So I first of all wanted to say thank you to all of you who are doing this, and bless you. And I wanted to ask very briefly, I've been getting some stuff online now about a connection between, I've had chronic fatigue for 26 plus years now, EMFs, electromagnetic fields, and the illness. There are some people out there writing some articles about the increase in our illness and the increase in EMFs, and I'm wondering if any of you have an opinion about that.
I'm a bit skeptical that that's the case, and mostly because I haven't seen any really well-controlled studies. There are some things you could do. In our laboratory, we have something called, it's a whole room, it's called a Faraday cage. And it's a way to build a room where there absolutely is no EMS coming into the room. It's nice because you go into that room and you cannot get a phone call. But that would be, it's not that difficult to make such a room. I think that would be of interest to actually have a person sleep in, especially the bedbound people, and see if there's any improvement. Things of that type is what I think would be more convincing. And we just need a really, it's more of a hypothesis, and the problem is we have hundreds of hypotheses. We got to test them.
Well, I'm skeptical too, so.
One of the things I think we have to be careful of is the fact that I think the patients are extremely sensitive. And I think it's the fact that there's something in the brain that doesn't block weak, stray signals. And that's what makes them sensitive to chemicals. They may actually be able to sense it. And we normally suppress those things, and we don't sense them. So the question is, does it cause the disease? And that's a different question. But I wouldn't be surprised that some people can actually sense that they're in a field.
Okay, thanks everybody. We have to vacate the room.
Yeah. Okay. I'll send you guys